Implanted ports. The implanted port is a surgically placed device that is designed for long-term intermittent use. When it is time for the port to be removed, it must be done by a physician in a hospital or clinic setting. The port catheter is attached to a septum, which is located just under the skin in a subcutaneous pocket. The device is ideal for intermittent infusions such as chemotherapy, as the access needle can be removed between each course of therapy. The port can also be used for continuous therapies, but care must be taken not to dislodge the port access needle. The implanted port is available as a single or double septum device and can be either open-end, requiring a heparin flush, or valved, using saline only. The port must be accessed using a non-coring or Huber needle to create an entry through the septum into the venous system. A standard needle should not be used, as this can damage the septum and possibly cause an embolism. Use of a positive pressure cap is optimal to prevent blood backup into the catheter and port septum. The port access procedure is done by a trained RN, or in rare instances, a trained caregiver. It is a sterile procedure that is completed weekly while being used for daily infusions, or monthly when not in use. Depending on chemotherapy cycles, it may also be accessed every 2 to 3 weeks for each cycle. If the port is being accessed monthly to maintain patency, 100 unit per milliliter heparin shall be used to flush the device. This may be reduced to 10 unit per milliliter heparin for more frequent use of the device. Flushing should be done using the push-pause method. The port is always flushed with 10 milliliters of saline prior to infusions to confirm needle placement, and is flushed with 10 milliliters of saline after infusions to clear all medication from the device. The saline flush amount is increased to 20 milliliters after parenteral nutrition and chemotherapy infusions and after lab draws. There are several complications that can occur with the implanted port. The most common are infection, occlusion, and infiltration. Infection can occur within the bloodstream or at the needle entrance site. In some cases, the port is removed and antibiotics are ordered to treat the infection. Good hand washing and strict aseptic technique are a must when working with the implanted port. An implanted port occlusion can occur when a fibrin sheath covers the internal end of the catheter, causing either a partial or complete occlusion. Blood backup into the port septum with improper flushing can also precipitate a port occlusion. In some cases, a declotting agent may be used to restore patency in the port. If this is unsuccessful, the port must be replaced. If the port remains accessed continually, there is a greater risk of needle dislodgement, leading to infiltration of medication and solutions. Other complications include malposition of the septum within the subcutaneous pocket and phlebitis along the course of the subclavian vein.